This is AJ. AJ is a young man who is known with rheumatoid arthritis. He woke up today with a very painful, swollen right knee that was so sore that he could not walk on it. AJ did not recall bumping his knee and did not know why his knee was so sore, and he decided that he should see a doctor. AJ arrives at your rooms and tells you about his acutely swollen, very painful knee. You take a detailed history, which reveals that AJ is a generally healthy 37-year-old who works in an office and has rheumatoid arthritis, which has been well controlled for the last 10 years. He has never had any serious medical illnesses or surgeries, and he partakes in light exercise a few times a week. You start your examination. An astute clinician, you noted that his gait was abnormal when he entered your rooms. He was avoiding putting weight on his right knee, and his gait was obviously antalgic. You perform a quick general examination, which reveals that AJ is pyrexial, with a temperature of 38 degrees Celsius, but is otherwise unremarkable. You focus your attention on his right knee. On inspection, the joint is obviously red and swollen and is fully extended. The affected joint lies in the position of maximum joint volume, be it full extension of a septic knee or the Faber flexion, abduction, external rotation position of an affected hip. When feeling the joint, you note marked tenderness and that the joint is warm. There is an effusion and the patella is ballotable. When moving the joint, you note that there is a reduced range of both active and passive movement. You make detailed notes in the patient's folder and think about your fifth-year medical school training when you did your orthopedics block. You remember that when faced with an acutely swollen and painful joint, it is critical to rule out septic arthritis. The most commonly infected joints include the knee, hip, shoulder, and elbow in that order. It is important to remember that deep joints, such as the hip or shoulder, may not present with prominent swelling and erythema. Some other possible diagnoses include gout, reactive arthritis, acute traumatic arthritis, osteoarthritis, rheumatoid arthritis, and septic bursitis. You suspect that AJ has acute septic arthritis, and take the basic bloods, which include an FBC, ESR, and CRP. You take a synovial fluid sample and send it for analysis and culture, and you book a knee ultrasound to confirm the joint effusion. You also book an X-ray of the joint, knowing that it is unlikely that there will be any radiological changes in the acute phase, but you want to have an X-ray to compare with after treatment. X-ray changes you expect in 2 to 3 weeks include joint space narrowing, periarticular osteopenia, and periarticular effusion. However, it is important not to delay treatment while you wait for lab results. Instead, if you have a high index of clinical suspicion, it is better to get started with treatment. Synovial fluid analysis and culture results come out and show a positive gram stain with gram-positive cocci, and the culture yields Staphylococcus aureus. The CRP and ESR are elevated, and the FBC shows an increased white cell count. The diagnosis of septic arthritis may be based on synovial fluid analysis and culture. A positive gram stain or culture confirms the diagnosis, and a presumptive diagnosis of septic arthritis can be made in the setting of purulent synovial fluid, with a white cell count of 50 to 150,000 cells per millimeter cubed, with a neutrophil predominance, but with negative cultures. The Kocher criteria is a pediatric scale used to assess the likelihood of a patient having septic arthritis and guiding the management. It looks at 4 parameters: temperature, ESR, weight-bearing status, and white blood cell count. However, the utility in adults is not well described. So you figured out that AJ has septic arthritis. Next, we actually have to manage his condition. Acute septic arthritis is managed as an emergency within 5 days from presentation. This is because the offending bacteria may secrete proteolytic enzymes, which destroy the cartilage and predispose the patient to secondary osteoarthritis. The management of septic arthritis consists of 2 basic principles: joint drainage and antibiotic therapy. Joint drainage. Essentially, septic arthritis can be thought of like a closed abscess and thus warrants drainage. Drainage can take the form of needle aspiration, arthroscopic drainage, or open surgical drainage called arthrotomy. The choice of procedure is made depending on clinical factors like the duration of infection and which joint is affected. Antibiotic therapy. The choice of drug is made according to local protocol and sensitivity, and must continue for a minimum duration of 4 to 7 days IV, followed by 2 to 3 weeks of oral therapy. Many pathogens are capable of causing septic arthritis, but the microbiology depends on the mechanism of infection as well as the relevant exposures of the patient. The most common cause of septic arthritis is Staph aureus, including MRSA. It has a particular propensity to adhere to synovial tissues. Other gram-positive organisms include strep pneumonia. In older adults with underlying immunosuppression, IV drug users, and trauma patients, gram-negative bacilli like Pseudomonas may be identified. Septic arthritis is usually monomicrobial, but polymicrobial septic arthritis may occur in the setting of penetrating trauma or polymicrobial bacteremia. Now you've got to wondering about septic arthritis. Who gets it, and how on earth does it happen? In AJ's case, he had pre-existing joint disease, which you know is a predisposing factor. Other predisposing factors include advanced age, over the age of 80, recent joint surgery or injection, soft tissue or skin infection, IV drug use, and immunosuppression like diabetes and HIV. Okay, so that's helpful and all, but how do these things land people up with septic arthritis? Well, they can be closely linked to the mechanism of disease. Septic arthritis develops via 2 main mechanisms. 1. Hematogenous seeding. Bacteremia is more likely to localize in a joint if there is pre-existing joint pathology, like rheumatoid arthritis, osteoarthritis, gout, or Charcot-arthropathy. Synovial tissue lacks a limited basement plate and is therefore vulnerable to invasion by bacteria in the blood. 2. Direct inoculation. Inoculation of bacteria into the joint occurs via bite wounds, trauma, intra-articular injections, arthroscopy, and joint surgery. This is why safe injection practice is so important. Other rarer mechanisms of infection may include contiguous spread from adjacent osteomyelitis and catheterization of femoral or subclavian veins. At the end of your consultation, AJ is asking what the likely outcome will be. Is he going to lose his leg? Will he ever be free of his pain? Unfortunately, this is a challenging one to answer, as there is limited literature on the long-term joint outcomes of septic arthritis patients, but it can result in severe functional deterioration, sometimes requiring amputation or arthrodesis. Factors like the virulence of the infecting organism, length of delay of starting antibiotic therapy, patient age, and the presence of pre-existing joint disease are known to play an important role. Luckily for AJ, he is young and was being treated by a knowledgeable UCT graduate who started antibiotics quickly, so things are looking good for him. Hooray!